So we are the national leader in geriatric care and wellness. We have the largest group of board certified geriatric PTs, OTs, and SLPs in the nation. We were really founded with a mission of, doing the best that we can for our older adult populations, built on the belief that older adults deserve the highest quality of care to help them live better and longer and really help to preserve, their dignity through all stages of aging. So specifically what we do, delivering evidence-based physical, occupational, and speech therapy tailored for the older adult population. So what that means is we're very familiar with other comorbidities that come with aging, things like Alzheimer's disease, dementia, Parkinson's, any type of, COPD, lung disease, other cardiovascular diseases. So very familiar with how those impact the human body, specifically how they impact the aging process. We specialize in serving these seniors in senior living communities. So we practice on site in these communities. And as Danielle mentioned, Amy and the rest of our team are on site at the Westmont at Short Pump in Richmond. We also do have virtual service models that are available mostly with our house call patients. We also do provide wellness programming as a part of our proactive care approach to maintain function and independence. So this would be more of one-on-one personal training or group fitness classes. So for example, at the Westmont, we do teach some group fitness classes for all of the residents. And then, we do partner with over 2,000 communities across the nation to help, reduce, transitions, preserve occupancy, and just improve overall resident engagement and experience while they are there. So I'll talk a little bit first about how we as therapists can help to support independent living and assisted living residents. So all three disciplines, PT, OT, and speech, are really key for helping to prevent falls, as well as maximizing functional independence for both the IL and AL resident. So the thing that I really like to make sure people understand is that falls are not a normal part of aging. And I think that sometimes, especially the older adult, can say, oh, well, they brush off that fall because, I'm getting older. That's going to happen. It really should not be a normal part. There are lots of things that we can do from a therapy perspective to try to help train the body to prevent some of those falls. So, being proactive with therapy, focusing on balance and fall prevention. So, fall prevention specifically being, balance training, but maybe a little bit of home modification or activity modification, talking about new ways to accomplish a task to reduce that fall risk. Our goal is to keep residents at or above their functional baseline. So this helps to reduce caregiving needs, maximize their independence with ADLs, which are activities of daily living, or IADLs. So that would be, ADL would be, bathing, dressing, eating. An IADL would be something more almost like a hobby, right? So they could, if we're talking about walking around the community, participating in community events, or working on communication and technology. So many things these days can be done virtually, just like this webinar, right? Or, maybe it's about FaceTiming family that lives far away. We can help with those sorts of communication goals as well, as far as helping to connect people to, the outside environment. We also complete home safety assessments and make appropriate recommendations and modifications. We help to supply residents with home exercise programs to maintain all those great gains that they made in therapy. Also helping to ensure residents are able to engage with the community how they want to. So everything kind of goes back to dignity and quality of life. We really want people to feel like they're at home and they can function in the senior living community, exactly like they were functioning in their own homes. And part of being able to achieve that goal is our staff working with the community staff for carryover of any recommended strategies to help improve that safety and quality of life. So, with maintaining mobility and independence, I mentioned that previously, conditions like Alzheimer's and other types of dementias they're all progressive and all can lead to the same thing: decreased activity, muscle weakness, shuffling gait. I know we've all noticed that in lots of people, postural instability, and just overall functional decline, right? So maybe they used to be a walker and they would go outside and they could walk for 20 minutes and they really enjoyed that. And then just over time, being able to walk shorter distances. And next thing you know, they're not going outside at all to walk, right? So that can be that overall slow functional decline. So, as PTs and OTs, we can help residents maintain that strength and endurance, preserve their ability to navigate their home environment, um, perform safer transfers, continue meaningful participation in all their daily activities. We can even help to adapt dining experience with modified plates, cups, and utensils as needed. So, for example, oftentimes, if we think about different types of arthritis that might affect the hands, it can affect how they hold cups and how they can hold utensils. So, there's ways that occupational therapy can work with them to address those impairments as well. So, the main takeaway of this slide here is really that even any type of small decline in mobility can accelerate an overall deterioration in that individual. So if you think about, if you don't do anything for a whole week, if you just sit in a chair and do nothing for a week, you'll lose some of that ability, that you had to be active and to be up and moving, and that is amplified a little bit as we age. So therapy is a really great tool in the toolbox to be able to help slow that trajectory. So from a fall prevention standpoint, if we're talking specifically with assisted and memory care residents, often they're experiencing impaired judgment, poor safety awareness, maybe some wandering behaviors, slower reaction times, decreased ADL participation, right? Maybe staff is having to provide a little bit more assistance, and balance deficits. So, specifically for the role of PT in these instances, we will go in and assess the fall risk, and then we create a plan from there to help address everything that we assess to be a risk. We work on improving balance and gait stability, maybe even recommending some assistive devices such as walkers and canes, and then using all of that information and helping to train the family and the staff in the senior living on safe mobility techniques so that they can help to carry over what we're trying to teach our patient during sessions. The role of occupational therapy, they very much assist with room modifications and assistive devices to decrease the fall risk, assist with learning ADL routines in a new environment. So, as humans, we do really well with routine, and especially in a new environment, it's important to set up those routines. And OTs are the professionals to really help with that. And then again, they are also working with the families and with the staff on approaches and strategies for successful engagement of residents with cognitive impairment, and also, providing ways to help, maybe talk the staff through a certain scenario, that maybe they experience something within their treatment session that the staff has been reporting. So they can walk the staff through, maybe how they were able to, get participation or talk the resident through whatever barrier they were seeing in that session. So the last piece that I'm going to talk about here is our role as far as respite care and also assisted living. So we're kind of unique in the fact that we do see patients as house calls. Um, so we can see them before, during, and after either a respite care stay or a permanent move into assisted living. So what this looks like, it's perfect example. There is a house call that we are seeing for therapy enrichment, and that individual needs some memory care support. So that patient is going to be moving into the Westmont, and we'll be able to take all of the information we already have about her and let the staff know. We can let them know what we've been working on, what kinds of needs that they have, and then transfer that care straight over to our in-house team so they can, continue to work with this patient and help get her adjusted to her new environment. It's a very seamless transition. It's helpful to be able to have some consistency in that way for families, especially. And if it's a respite case, we can also then follow that person when they move back home. So it can very much be this fluid plan of care if it's not a permanent move. So some of the benefits of this would be, like I mentioned, being able to assess the resident in the home before they even get to the assisted living. So we can go ahead and create a therapy plan and then be able to communicate those needs to the staff, helping to determine the level of support they will need during that stay. The patient's plan of care will be transitioned to the team that's already within the senior living to work on those areas of need, helping the resident maximize therapeutic gains by seeing them on site, and then being able to collaborate in real time with the staff on care plans, helping to create a discharge plan if it is a respite stay, and then just being able to continue therapy for the resident in the home, again, if it's respite and they are planning to move back. So I'm going to stop here. I'm going to switch this over to Amy, and she'll talk a little bit about our role in transitioning specifically from assisted living into the memory care neighborhood.
All right. So, just like Kate was saying, like therapy within the senior community is integral in helping them to get more established and to get into a routine. This exact same thing happens when we have a resident that's moving from assisted living into memory care. If services were being provided in assisted living, nothing stops. We're going to continue those services in memory care, helping them in their new environment so they can be the most successful over there. But we also sometimes, haven't had somebody on services and they start to transition into memory care, and we realize, what, they really need a little bit more support. So PT, OT, and speech definitely play a major role in helping with that. Often it's determined by the changes in their cognition, behaviors they might be having, communication difficulties, which that's when speech therapy comes into play, and then their independence, of course, and physical function, because we want them to be able to do the activities back on the memory care unit, and enjoy that their time there. The therapy disciplines all do work together with the community staff to be able to maintain the function, to help enhance safety, and of course to support quality of life, because that's our ultimate goal. Next slide. So when we move into memory care, that often means several things are going to change. There's going to be a new room layout. Here at the Westmont, that often means it's going to be a single room. They may have been previously in an apartment that had multiple rooms. They will still have their own bathroom, of course, so they do have their privacy. But it means that we're going to have to probably downsize some of the things that we've had, and therapy can be very helpful with assisting family members on what adaptive equipment we're going to need, as well as the what's the most pivotal pieces of furniture, so it still feels like home and it doesn't look like a completely new setup for them. Dining is going to be a little bit different. It'll be smaller, more intimate, and it may require more support from staff. The bathroom configuration is going to be different. There may not be as much decor in the bathroom as what we had before, because we want to keep things pretty simple, but that doesn't mean that we can't have it looking homey still. And they're going to, of course, need increased supervision, because that's why we're coming to memory care, for that support so that we can help them to thrive. PT and OT can help with reassessing functional abilities in this new environment. We may have to look at, we're not as concerned about as many obstacles, because again, we're going to have that smaller environment. We're going to try to be minimalistic with our furniture and items that are in the apartments. We recommend environmental modifications. Sometimes it doesn't work for mom to have a recliner anymore. Maybe mom is not safe with remembering to put the legs of the recliner down. So we need to come up with a different kind of a chair. Training the residents to safely navigate the new space, that takes a little bit of time, but of course that's getting them into their routine, understanding every morning, the staff is going to come in and get them up, and then we're going to go into the dining room, we're going to have breakfast, and then maybe it's time for some physical activity in the living room. And as they get in their routine with therapy and the staff support, that will help them with learning their new space. Sometimes it involves educating caregivers on mobility needs. The resident may be familiar to our employees from them working on the assisted side as well as over in memory care, but maybe some of those needs have changed. And so we need to come up with different assistive devices to use to keep them independent and moving. But it also may mean that we have to give them different cues than we had to give them before. Instead of 3 and 4 things on how to get somewhere, maybe it's a one-step command now instead that we're training them on. And then, of course, we're going to work to prevent unnecessary decline due to the environmental change. So again, not stopping those therapy services if we were in assisted living. We want to continue those because that's something familiar to them. And then if we're new to therapy services, we want to be as consistent as possible so that we can have the best success. Next slide, please. So physical therapy, our primary focus is going to be on mobility, strength, fall prevention, and safe movements. Those that have dementia are definitely at a much higher risk for falls. It's due to that impulse control. Their judgment is not what it once was, and their reaction time is slower as a result of all of it. And they do have poor balance. We do see weakness and deconditioning. When a resident gets to a point where they need some memory care support, they might not have been participating in as many social activities. So they may have been more sedentary prior to moving into memory care. But now everything's going to be on a smaller scale, so it's going to be much more manageable, and getting them back into that routine will help with getting more walking in and helping with the deconditioning so they can get stronger. Often we find that PT does maintain their independence longer. We do reduce hospitalizations through fall training, balance retraining, and like we said, the modification of the environment. And then it increases the overall comfort and safety of not just the resident, but also the family as well. Common interventions you'll see a physical therapist use will be gaits, and that could be without an assistive device. It could be with a walker, with a cane, balance training. Sometimes we're using foam pads to help with that, because when we have a beautiful courtyard that we want to take our residents to. There are It's not perfectly flat all the time. Like there may be inclines and declines, and that resident may want to go over and bend over and look at that flower and step in the soil, and we certainly don't want them to fall. So we're going to come with different textures and surfaces for them to work on their balance. We have strength exercises that we work on, transfer training, whether it's from a bed to a chair or to the toilet, getting in out of a soft recliner chair or off the sofa in the living room. We do work on fall risk reduction strategies, assistive device selection, like I said before, and then not only training the individual, but sometimes we're training family or the staff. And then pain management that could be due to arthritis, and that will limit mobility as well. Next slide. OT is going to be more focused on daily living skills, like Kate was saying previously, sometimes like eating, using utensils that make it easier for them to manipulate the food on their plate, getting them established in routines. Again, we double up on safety, and then adaptive equipment. They may have different adaptive equipment for the resident to be using. So occupational is important because dementia progressively will affect their problem-solving skills. Their sequencing is typically off with grooming. Sometimes we might put their undergarments on the outside instead of on first, and then put our lower extremity clothing on. So occupational therapy helps to work on that sequencing task so it's less confusing, and the resident can feel confident. The ability to recognize hazards becomes a problem. So of course we want to look within the environment, what can we get rid of that could potentially be a hazard? And then overall, I mean, occupational therapy just supports dignity and gives that resident autonomy and helps them to participate in everyday life with success. Common OT interventions you might see will be training or cueing for activities of daily living. Again, that's the bathing, dressing, grooming, and toileting. Setting up routines that reduce confusion. Again, that just comes down to like figuring out what single steps work best for that individual. So it's very customized. It's not a cookie cutter approach to that. Using visual cues or labels or memory supports. Sometimes we have signs in the apartments that have a sign that says, bathroom, and it has a toilet on it. So it makes it easy for them to identify, oh yeah, that's where I want to go. Environmental modifications to help reduce their agitation or their risk of falls. Lighting can become very important. Sometimes a lamp in a corner turned on can create shadows that can seem scary to individuals. So sometimes, we want to make sure that our lighting is appropriate. It's not too bright. That can sometimes overstimulate, but also that it's not dark and it causes trip hazards. Furniture placement is very important because we don't want trips or falls. And then simplifying those spaces, like I said before, making sure that we don't have every square inch of the apartment with something in it, and it makes it difficult for them to maneuver within their space. They often work on hand use with fine motor strengthening. So sometimes they'll have like putties that they'll be working on, or TheraBands. Sometimes we have these TheraBand, I'm blanking on the name right now, twists that help with strengthening wrist and grip strength. And then engaging them in purposeful activities that they find stimulating, not just something that like maybe you or I would enjoy, but something that is something they've enjoyed over their lifetime. Next slide, please. Speech therapy is primarily focused on communication, cognition, and swallowing. Speech is important with our residents that are maybe having difficulty finding words or expressing thoughts. Those typically tend to be on our GDS scale, more of like our level 5. So somebody who can still carry on a conversation, but they're still having difficulty with finding that one word. Where there's still a lot of success with that. Trouble understanding, if they're having difficulty understanding spoken or written languages, sometimes that's helpful to have speech therapy. Memory and problem solving deficits, dysphagia, which is swallowing difficulties. And we certainly don't want that, because that oftentimes can lead to aspiration, which can cause pneumonia. So the speech therapist may temporarily change the diet and work on some swallowing strategies and some strengthening exercises to help, so we can try to get them back to the diet they were on. But ultimately, safety is our biggest goal. And then some of the common interventions you might see, the communication strategies they can use would be simple language, gesture systems, picture boards are sometimes utilized for them to be able to, point out what it is that they actually want, because they can't find the word. That's a good technique. There's cognitive linguistic therapy for attention and memory, as well as safety awareness. They often do swallow assessments, which often comes from the staff. However, it could come from a family member who's noticed that maybe mom or dad is drinking, and every time they take a sip of something, they cough immediately afterwards. And that certainly is not a problem to just do a quick assessment and make sure everything's okay. And they do help with diet modification as a result of that. So sometimes we have to go on those thickened liquids or go to a puree diet. And then educating caregivers and staff on safe feeding and communication techniques. Next slide. Ultimately, when they move from assisted living into memory care, we want them to have some kind of a structured routine and behavioral regulation. Residents with these impairments benefit from lots of repetition. So like I was talking about with the schedule, with getting up in the morning, going to breakfast, and there's some kind of physical activity. So they can always count on it being a movement task. It might be a different movement task each day, but it's going to be a movement task. And then maybe some kind of a mid-morning snack, followed by some quiet meditative time before going into lunch, and so on and so forth. The predictable routines help to decrease anxiety, which oftentimes helps to decrease behaviors that we might see with residents as well. And that structured activity just really helps to support. Therapy sessions often provide meaningful physical engagement. Like I was saying, if you want to keep moving, otherwise we become deconditioned. There's a saying of, if you don't move it, you lose it. So we certainly want them moving as much as possible. It gives good sensory input to help them stay oriented to tasks that are happening. It gives them purposeful movement. If we want them to be participating in activities that are salient to them. And it reduces agitation and restlessness. Physical activity has often been shown to improve mood and decrease behavioral disturbances that you find common in dementia. All right, so when we help with these therapies, we often see that there is a slowing of the physical decline with the progressive diseases. It doesn't necessarily, it's not going to stop it or halt it, but it certainly does slow it. We may have periods of time where we're kind of maintaining at that new level of care. And certainly we hope that we can maintain that for a very long time before there is another progression of the disease. But when we do get to that point, that's why we have therapy here as well. What else can we do to try to keep them as independent as possible, as long as possible, with the best quality of life? So, regular PT and OT can help maintain joint mobility. It definitely reduces the contracture risk. So, a contracture is when a limb is not being moved and it's kept in a position, it can end up permanently being in that shortened position. So, we don't want that. It's very painful for residents, and it can make it difficult for transferring. It can make it difficult for hygiene reasons as well. We certainly want to prevent deconditioning. We want to support respiratory health by movement. And we, even in those that have moderate to advanced stages, the movement does still help to preserve their dignity and comfort. Next slide. So, of course, therapy is wonderful, but it only goes as far as us being able to communicate with the rest of the team. So interdisciplinary care is very important. We make sure that we're discussing with the CNA staff back there, as well as nursing staff, the physicians that round back there, even housekeeping. It's important for housekeeping to understand what could cause slips, trips, or falls, or if the resident is having a difficult time communicating, how they can communicate with that resident. Every person back there plays an integral role to helping with the success. So we certainly want to make sure that we are having safe care plans, that we're talking about proper equipment use, appropriate activity levels for the staging of their dementia. We want to talk about residents, what's appropriate for them to engage in, as long as it's a familiar task or an interest that they previously had. And then obviously realistic goal setting. Next slide. There we go. So quality of life and dignity, we obviously want to keep them as mobile as possible because that does give them their autonomy. That allows them to go out into the courtyard to look at the beautiful flowers during the day if that's like what they want to do, to go enjoy that music class back in the Inspiritas classroom, or participate with gardening or dance, whatever is of interest to them. So we certainly want to keep them as mobile as possible. Residents are able to retain a sense of identity and dignity when we keep them moving, and that's most important in memory care. And we certainly want them to be able to ambulate as much as possible to meals. Sometimes that means that a caregiver is walking beside them with that walker to make sure that they're doing it safely and staying in the walker, but we're still going to let them use that walker because mobility matters. Standing with assistance, we want them as independent as possible. So if they can stand to brush their teeth safely with someone next to them, that's exactly what I want them to do. They're using those muscles, they're working their balance, and they're doing something that's familiar, a task that's familiar to them and keeps them as independent as possible. I certainly want them transferring with as little assistance as possible because they've always been able to do it. They've been independent, and I want them as independent as possible. And then participating in activities that matter to them. So just to sum everything up, therapies during the transition from assisted to memory care help to reduce fall risk. It maintains the strength and independence as well as their mobility, supports behavioral regulation, assists with environmental adjustment. It slows that functional decline and enhances quality of life. Therapy often acts as a protective and stabilizing intervention, and this can be one of the most vulnerable phases of the resident's care journey. So it's not something we enter into lightly. We definitely want to make sure that we are taking care of every aspect of their health.
Awesome. Thank you, Amy. So at this point, we can go ahead and open it up for questions if anyone has questions that they would like to ask.
Yes, thank you, Kate. Thank you, Amy, so much. What a wealth of information you all have shared with us this afternoon. Like Kate said, if you all have any questions for us, you can go ahead right now and pop those in the chat. We'll get those answered live for you while everybody's typing away. I actually did have a question for you all. I know today we heard a lot about the many benefits of all the different types of therapies and how they can benefit in all stages of aging. I'm curious, what an individual would need to be able to get started with therapy. Could you talk me through that process, and maybe any financial steps that are involved in that?
Sure, definitely. It's a great question. So we are an outpatient therapy provider, so we bill everything to someone's insurance. So if you have Medicare, we're billing to Part B of Medicare. So I would say step one, it would be most beneficial to reach out to see if what your insurance benefits are. So we can always get that information ahead of time, run the benefits, and be able to come back and let you know if there might be a copay or anything like that. So to be seen by therapy, we would need insurance information, a referral for therapy from your doctor. So it can be your primary care neurologist, orthopedic, rheumatologist, anyone that you're seeing can write an order for therapy. And then that would be it. If it was somebody maybe in memory care, we would need contact information for their power of attorney, whoever the decision maker is, to be able to collaborate with them on getting consent for care and just really keeping them in the loop about the memory care resident specifically.
Perfect. All right. Well, it looks like we do not have any other questions at this time. So I do want to go ahead and thank Kate and Amy so much for taking the time to join us today, bringing us your knowledge on therapy's involvement in aging and caregiving. On behalf of Retirement Unlimited Incorporated, I want to thank each of our viewers for joining us today. We hope to see you guys back here on April 15th for our next RUI-informed webinar, where we'll be deep diving into Parkinson's disease, movement, mind, and medicine. Thank you again and have a great evening.